Good afternoon and welcome to our Cardiac and Vascular Lecture Series. I am Dr. Khaled Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you have the ability to ask questions via the Q&A feature located at the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Ghoreishi, who will be presenting the lecture titled Cutting-Edge Techniques of Endovascular Aortic Repair. Dr. Ghoreishi is a board-certified cardiothoracic surgeon. He is the co-director of aortic surgery, medical director of cardiac surgery research, and the John and Margaret Krupa Distinguished Chair at Baptist Health Miami Cardiac and Vascular Institute. Dr. Ghoreishi specializes in adult cardiovascular and cardiac surgery and has a specialty in clinical interest in aortic surgery. He is highly skilled in both open surgery and minimally invasive catheter-based treatments of aortic diseases, including endovascular treatments of ascending aorta, aortic arch, and aortic root. He is the most experienced specialist in the United States and performs of normothermic, normal body temperature aortic operations, as well as endovascular aortic arch and aortic root repair. Dr. Ghoreishi earned his medical degree at the Beheshti University of Medical Sciences in Tehran, Iran, where he also completed a general surgery residence and served as a chief resident. After finishing his general surgical training, he joined the Cardiac Surgery Research Fellowship Program at the University of Maryland School of Medicine. He served as a chief resident during his cardiothoracic surgery residency and was awarded the American Association for Thoracic Surgeons Denton A. Cooley Fellowship. Prior to joining Baptist Health, Dr. Ghoreishi was a co-director of the Center for Aortic Diseases at the University of Maryland Medical System and associate professor of cardiac surgery. He led a team of professionals who developed less invasive treatments options for patients with aortic diseases and developed and performed the world's first endovascular repair for aortic diseases and dissection. His groundbreaking approach allows the replacement of part of the aorta and aortic valve using the endovascular technique, eliminating the need for traditional open heart surgery, which carries a higher risk of complications and mortality. Dr. Ghoreishi is a co-inventor of two medical devices and holds multiple patents and licenses in the field of cardiac surgery. He's dedicated to improving and imparting knowledge to the next generation of cardiac surgeons. He frequently presents at national and international meetings and is widely published in peer-reviewed publications. He has received numerous honors in his clinical expertise and research and teaching in the cardiac surgery field. We're really honored to have Dr. Ghoreishi with us. Thank you so much for making the time to be with us, Dr. Ghoreishi. The floor is yours.
Thank you very much, Hakim, and for your very nice introduction. And I'm Mehrdad Ghoreishi. I'm the director of Aortic Center here at Miami Cardiovascular Institute. And so my talk is about the future of aortic surgery, cutting-edge techniques and research. For the last decade, the management of patients with aortic problems has really evolved and has changed. And from very high-risk, unsafe intervention, it's now changed to a very safe and with very outstanding outcomes for these patients, because of the technology that is now available for us, because of the surgical techniques that has evolved, the timing of the procedures for these patients. So I'm going to go through these evolutions of management of aortic problem. Just before I go through the details, I just wanted to mention that aorta is now by the American Heart Association guidelines is recognized as an individual organ. It's exactly like brain, kidney, liver. Aorta is an individual organ and needs specific attention. And as you can see here, it has 11 segments, and this part is attached to the heart, and this is the part that is called aortic valve, aortic root, ascending aorta. Here it is called zone 0. These are aortic arch. These are the head vessels that giving the arteries to the brain. And then this is the descending aorta, a part of the aorta that is running backside of the chest behind the lungs. And this is abdominal aorta, giving arteries to the kidneys, liver, gut, and then comes and gives arteries to the leg. So all of this part, all of these 11 segments can become diseased over time when patients age or family history or patients with high cholesterol either dilate or become stenotic or dissect, rupture. And it's a common disease. It involves about 5 to 10% of the patients in their patient population in the United States in their lifelong. So it's common. And again, if you scan me when I become 7-year-old, at some point my aorta will dilate because it's age and dilate. So our goal is to identify those patients who have a dilated aorta and either treat them before they rupture or we monitor them before it becomes dilated and ruptured. So the aortic procedures that can, for patients who require aortic valve procedure or aortic root replacement, any of this, now the operation is very safe. You can see with a mortality rate less than 2%, that we replace this part of the aorta that is attached to the heart. It used to be 10-15% mortality rate. It's now less than 2%. Very safe procedure. Ascending aortic replacement is for patients with aortic aneurysm. It's now very common. I just did it today, did it yesterday. Just every day we have these patients that require ascending aortic replacement because of the aneurysm. And now it's very safe procedure. Mortality less than 1%, stroke risk less than 1%. Aortic arch procedure, as you can see now, replacing all of these parts. It's another, modalities that we offer for patients with aortic problems. We can replace all of this part of the aorta. It's called thoracoabdominal aortic replacement. It's a big operation. And the open procedure, I can say, still the outcomes are not very still there, still acceptable, but compared to other part of the aorta, the outcomes of this big operation is not very ideal, and that's why endovascular procedure for these is really become very hot topic. And then again, as I mentioned, endovascular aortic repair. For every part of this aorta, we can offer endovascular. Endovascular means we fix the aorta from inside, going from these arteries in the groin and put a stent in every part of this aorta that is diseased, either dilated or ruptured or tear in it. Instead of doing a big operation, we can go from the groin arteries and fix them from inside and put stent in them in every aspect. And Baptist is currently the only center, I can say, in the whole world that can provide endovascular repair for all of this 11 segments. And why I'm saying that, because right now we are the only center that can provide endovascular aortic root repair, which not any other center can do that, but every aspect of this aorta, we can fix it even with endovascular repair. And this is how it looks like from inside. It just, we stent them, it's like a puzzle, we just make them from inside. The guidelines have changed for patients with management of aortic disease. It's now 5 centimeter aorta, that every part that require replacement. It used to be 5.5. It's now 5 centimeter. That's important to remember. And then follow-up is important. If on 2 consecutive CT scan, the aorta is dilating more than 0.5 centimeter, that's an alarming sign. That's a sign that patients can rupture soon, so something needs to be done. In our center, we can provide aortic valve repair. It's very important, like just like a mitral. If people remember, in old days, if you had a leaky mitral valve, everyone would offer, oh, okay, let's replace this valve. But for mitral, things change, and now repair, providing better outcomes. Now it's for aortic valve as well. For severe aortic valve, we can repair the valve, keep the patient's own valve with some technical procedures, so the patients wouldn't require anticoagulation, wouldn't be at risk of endocarditis or complications related to an artificial valve sitting inside their heart. Aortic valve repair is now here, and we can provide that. If the aortic root involving the aortic valve is dilated, we can provide this very technically demanding procedure. It's called valve-sparing aortic root repair. That means we resect all of this aneurysm, keep the patient's own valve, do all of these reconstruction, and then invaginate, put that valve inside this graft, Dacron graft, artificial graft, that when we resect all of that bad tissue aneurysm, we use this Dacron graft so that it transfers the blood to the rest of the body. Very safe procedure, as I mentioned. And then the other part, ascending aorta, ascending aorta with aortic root, or ascending an aortic arch replacement. All of these procedures can be done with acceptable outcomes. Aortic arch replacement, its multiple techniques have been offered. You can see on any of these images, you can see how challenging these things can be. But with the new technologies and stents that are now available, we offer these procedures here with a technique we pioneered. It's called normothermic total arch replacement. We replace all of these head vessels without even cooling the patients, without disrupting the blood flow to the body, and with the new technologies that we have. And then, as I mentioned, for thoracoabdominal aneurysm requires this big operation. However, we have this access to this device technology that is called TAMBI. It's all endovascular thoracoabdominal repair. You can see from the groin, this stent goes up there without even making any incision, and put this stent where exactly we want. This stent goes inside the aorta and basically covers the aorta from inside, covers that aneurysm so the aorta doesn't rupture. And again, these devices are now in our hand, and we can fix any aneurysm, any dissections, anywhere part of the body. You can see how these devices work. If the anatomy is not suitable to use any of these FDA-approved devices or the devices that are made from the companies, we can build it on the back table for the patient. This is a patient that every company rejected to offer any stent, but we built this stent for this lady, and I just used this graft, made 4 holes in it for the kidney arteries, for liver, gut. You can see I sewed those stents to this main body stents, and then put it back inside the sheet, made it like a pencil size device, and then put it from the groin arteries, and then from each of these holes, I access these holes and put a stent into each one of these arteries, kidney arteries, SMA, celiac. And this is a lady, 81-year-old, came with a thoracoabdominal aneurysm. And as you can see, with a very horrible access, like it's very vasculopath and disease arteries, but we have access to the very low profile devices, stents. I made that stent for this patient, and then you can see here I'm making this stent with the resident, making these holes and then stent them and then resheet that exactly like that. I put it back inside the sheet. So it becomes pencil-sized device. It goes from the groin, and this is the lady post-op day 1. She went home with this, fixed aorta. She came with abdominal pain, found to have near rupture abdominal and thoracoabdominal aneurysm, and she went home post-op day 1 with no complications. So the endovascular for thoracoabdomen is for descending aorta is really the technologies that is now here. Instead of making big incision, very high morbid mortality procedure for abdominal and thoracoabdominal, we now have access to all of these endovascular minimally invasive stents that we can fix these patients. And used to be when the patient was 75 or 80-year-old, we would say, you know what, you're not going to tolerate a big abdominal or thoracoabdominal aortic repair. But we just did an 88-year-old. I showed you. We just did another 91-year-old last week, and with all endovascular, and they all do fine because it's all minimally invasive, 3-4 hours procedure, but no open operation, and patients go home with a very fast recovery. Aortic dissection is another term that is very important that aortic centers can manage. This the patient comes with a tear in their aorta, and as you can see, the aorta is torn. The aorta shouldn't look like this, and you can see how thin the aorta becomes because now there's a tear inside, and the aorta comes blood comes out of to 2 lumens, 2 channels from this tear here. And that's why the aorta looks very angry. You can see it's almost near rupture. So we manage them here in a very multidisciplinary team with a rapid transportation, resuscitation, which is extremely important. Hybrid operative room, all of these patients, we assess them that make sure that, okay, they need endovascular or open, what's the best modality to fix them. And then quad aorta team, cardiac surgery, vascular surgery, interventional radiologists, they all get involved with these patients because these patients are sick and they require multidisciplinary team. Cardiac surgery does procedure, and now, okay, after 8 hours, 9 hours, 5 hours, they are a little bit tired. So cardiac vascular surgery and interventional radiologists get their hands on, fix the other part, for example, abdominal aorta that is ruptured or the leg that is ischemic. So all of these teams need to work hand to hand, make sure these patients get the best outcomes. It used to be very high mortality to, like, if you Google type aortic dissections, they all say it's the highest mortality, 60%, 70% die, but I can show you the outcomes here. The signs and symptoms of acute aortic symptoms can be totally varies from asymptomatic patients to patients come with a stroke, patients comes with hoarseness, they can't talk, they come with shortness of breath. So all type of symptoms, they come with heart attack. Aortic dissection can come with multiple symptoms. If a young patient, 40-year-old with a history of aneurysm or no history of aneurysm, but family history of aneurysm, start to have chest pain or any of these symptoms, we have to be concerned about dissections, shock, stroke, syncope. Even patients come with they are bleeding from the gut, all of these, or lower leg ischemia. The first test, we have to get a CT scan with contrast to see the location of the tear. That's the guidelines now, as you can see here. But that's the best test. We do not worry about kidney. Okay, creatinine is up. No, the best test is the CT scan with contrast to see where we are. We control their blood pressure with some of the specific medication. And important is get them to the hand of surgeons, aortic centers that to fix the problem. That's the first thing, is to transfer these patients to the hands of cardiac surgery, or the team that can manage these patients. And there are other modalities treatment, but we have to control the blood pressure, make sure it's less than 120, and then transfer them. The outcomes for when the aorta dissects in the whole United States is not good. You can see mortality is high, 20%. And if the extensive of the procedure goes high, it can even go to 25%. You can see it's not, it's very high mortality operation. However, this was my passion for a get-go. I was always wondering why these patients' outcomes are poor. I studied them and I look at them, and we came we came up with this, innovative way to facilitate the procedure a little bit, make it easier, decrease the amount of operative room time, decrease the amount of blood transfusion, and all of that. As you can see here, became like this. This is the device. This is the stent that I put in during for these patients and do these procedures. We brought down the operative mortality that nationally is 25% to 5%. So very good outcomes. It used to be 17, 20%, but rarely aortic dissection, which is a sick patients these days, die because of these innovative way to fix them. I pioneered this technique. It's called normothermic total arch operation. And I mentioned that instead of being in the operative room for 8-10 hours, cool the patient down, stop the perfusion to the body to reconstruct all of these head vessels. This stent is available. We can do it here. And with this innovative way that we started, is we don't have to cool. We just put this stent in, and then we come back on the pump for the body. So basically no stop to the perfusion to the body, and no CRS. Operation that was 8 hours is now 3 hours, and patients do very well. This is, for example, one of these patients that I do it this technique. I'm not going to go through the details of this, but that's how for aortic dissections or aneurysm. I'm going to just show it the part that we put that stent, and shows so that's the stent. Oh, here we go. So that's the stent that we have here. It's called Toraflex device, and it really facilitates the procedure. You can see this device goes in, it gets deployed, and then done. But basically, we just come back to the perfusion to the body. Again, not that few centers probably have these access to these devices, and especially this technique that we do really only centers in the United States that can currently do these type of procedures, normothermic total arch replacement. This operation, you can see with all of these total arch, CABG time 2 vessel bypass on a 400 pounds patient, 77-year-old. It took only 3 hours procedure, CRS time 6 minutes, 4 hours procedure. Patients went home post-op day 4, no blood transfusion. On a 77, 400 pounds. That's pretty amazing. This another device that we have access to. That it's patients for acute type A. It's basically for patients that surgeons that adult cardiac surgeons. And so when I'm not on call every time because I do total arch, use that device, but that's a little bit technically demanding. We brought this device for so that adult cardiac surgeons that they face in emergency situations, and I'm not around, then this device really facilitate the procedure and make the operation easier. I'm going to skip through the video of this. And so I studied a lot about why patients with type A dissections mortality is high, and this is the algorithm we actually now follow. We found out because we are taking these patients to the operative room to give them very big procedure when they are sick. if they are not sick, they actually do very well in the operative room. But when they come sick, if you take them to the operative room in that sick situation, their lactate is up, they are in shock, they are intubated, all of that, they actually either die in the operative room or they die after the procedure. Therefore, I came up with this algorithm that endovascular therapy actually would be better for these patients because it's going to be minimally invasive, not too much time in the operative room. Patient selection is the key. This patient is an 85-year-old, came with acute type A. We look at her, she was very strong, not frail. She wasn't sick. She just had chest pain and this type A dissection. And she also had a severe aortic stenosis with this tear. Right? So we gave her an open operation because she was good, fit. This is 30 days after the procedure with her cardiologist. You can see she was a strong 85-year-old. However, you can get this patient, 78-year-old patient, had a history of double valve operation. She was on Coumadin. Her INR was so much high. Her liver and kidneys were not getting blood perfusion. She was on renal failure. If I take this lady to the OR, she's gonna die with these situations. So the best condition is actually doing endovascular. This lady, you can see she had a tear in her ascending aorta. She also had a rupture in her descending aorta. So if I do open operation, she's gonna die. But we decided that the best option is endovascular. So we just stented her ascending aorta from the groin and stented her descending aorta again from the groin, all endovascular. And she went home post-op day 5. No open heart operation. This is another device. It's called TBE. It's FDA-approved device for endovascular arch, not the total arch, but just part of the arch. You can see we have access to that. This device goes up for if there's a aneurysm or rupture in the aorta right at the artery going to the left arm. You can see this device goes up. It deploys, and the blood, instead of going to this aneurysm, it goes to this graft. And it has a side port for this vessel, which is left subclavian artery. Again, in old days, we had to cut open the patients and replace all of this aneurysm, but now we have access to these stents. And this is how technology is helping patients. These are all of the devices that we can are in the line for endovascular arch procedure. Doing all of those open that I mentioned, we can have all of these endovascular arch still for patients that are not suitable for open, because open is actually pretty good. It can, if in a hands of aortic surgeon in aortic center, outcomes are good. And this is a device that we have access to, that we are actually performing the second patient in the whole country, hopefully soon, with this device. It's called Nexus device, and this is for patients with aortic arch. You can see how the arch is dilated, and this is a stent graft. It goes to the one of the head vessels, and this stent gets deployed and fix that. You see how this stent opens up and cover this aneurysm here. You can see that's the end of solution. That's the end products. If we don't have access to any of these stents because of patient's anatomy, or FDA or company says no, you can't use it because this anatomy doesn't fit, we can do that. We can, I mentioned that before, we can make it for the patients on the back table with the available stents we have. That's what I do, is we either 1 vessel fenestrations and extra anatomy bypass, 2 vessel fenestrations, you can see, or 3 vessel fenestrations. These are example of, I just make the graft on the back table, put 1, 2, 3 holes, depends on the anatomy, and then put it back inside the sheet, deploy it from the groin, and access those holes and stent them. This is 2 vessel, this is 3 vessel, you can see fenestration. And that's what the example I told you. I mean, I deploy this stent on the back table, exactly like I open it, I make 3 holes for the head vessels, and then put it back inside the sheet, and then go from the groin, deploy it, and stent through these holes into each of these head vessels. It's called PMEG, physician modified endograft. It's another example of patients came with the aortic arch dissections and rupture. I just did this with 2-vessel stenting. Instead, he wouldn't tolerate open operation. Ascending stent for endovascular ascending aorta is you can see this is available. We can do it here. This a patient came with rupture of the aorta, you can see here, and we can easily put an ascending stent with her and cover that rupture. So it's this device that we have access to that. It completely stent this ascending aorta. This is another example, came 77 after trauma car accident. She had a rupture here, and I just stented her ascending aorta. So no more open heart operation. And the final thing that I want to mention is endovascular aortic root, that currently it's only we can do that, and we publish it in circulation with we came up with this device that we can attach a transcatheter valve to a stent graft, make 2 holes for the coronary arteries. And this is for patients that they have aortic valve and aortic root aneurysm or dissections, tearing that, and they can't tolerate open. Other option was just more hospice care. And we can use this device. You can see how we have done it. And it's very challenging innovations, but you can see I use a transcatheter valve, I use a stent, sew them on the back table, get them ready, make 2 holes in the graft for the coronary perfusion, right on the back table. While the anesthesia is putting the patient to sleep, I make this device for the patient. I trim the nose cone of the device because it's very long, it can rupture the left ventricle. So I get the device ready, and this is the final device that I put it in patients. And this is the case that we did for endovascular aortic root. You can see this device gets open, and these are the 2 holes that for coronary perfusion, how is perfusing. And then we access the right coronary stented, we access the left coronary stented, and do a total endobental. And this is the final angiography. And this is the example of a patient. This is the aorta. 85, 81-year-old came with this size aorta. I mean, humongous, ugly looking aorta, not an open surgical candidate. And with all of the endovascular procedures that we did, including endoarch and endobental, this is her final CT scan. She is still alive, 2 years out of her endobental, endoarch. In old days, these patients wouldn't be alive right now. And that's her CT scan. I can say I'm very proud of this work. A few works I can say, but this is extremely revolutionary. And so we patent this device. It's not like we can do this anytime. We already have done it one time, and we keep going. So final is every aspect of this aorta, we have a solution, open and endo, and this is amazing because this was not available even probably 2 or 3 years ago. So what is the future state? This is a textbook by Alan Lambsden. He's the chair of the Houston Vascular Center, and this is his book in 2007. He said, what do you think this patient will get in future? And this is 2007, and he was thinking, okay, endobental, coronary stenting, ascending stent, neuroprotection device, arch protection device, a stent here. We are doing this. So 2024, this is the future of here. And so that's amazing. Management of aortic disease have changed. Collaborative team is important. Cardiac, vascular, interventional radiology, all together, working together, share decision with patient, what's the best option for the patients, and very multiple meetings, about these patients in aortic center with multidisciplinary team involved, talk about every patient multiple times to come up with the best plan is something that I want if I have aortic problem. Thanks so much.
Dr. Ghoreishi, revolutionary indeed. Those words will resonate for quite some time. We're not only honored to have you on our team at Miami Cardiac and Vascular Institute, but truly exceptional work that you have done that has resonated throughout the world. And we are extremely, extremely proud of your accomplishments. You did mention Baptist currently is the only center in the world that can perform endovascular aortic root repair in all segments of the aorta, all 11 segments. That is absolutely remarkable. Now, I'm sure some of our peers were always going to wonder, how can we select patients in order for them to qualify for these type procedures? You also mentioned that obviously you have to work with the organization that will provide you the devices to actually qualify the patient in order for the stent to serve the purpose. But what is amazingly remarkable is the fact that you can actually customize the device for the patient right there and then while they're doing the anesthesia. So, sparing so much suffering. I remember in every single physician online today remembers how complex and how scary and nerve-wracking this is, not only for the patient and the family, but more so for the entire cardiac team. For you to now consider the aorta as not only an important organ, but something that can be repaired remarkably. I was astounded. I honestly did not know that you did it in 3 hours. That is absolutely phenomenal. We remember, Dr. Ghoreishi, and you probably, when you were a resident, these patients will remain in the hospital for a long period of time with the traditional open heart surgery, and then we will all have to pray for good outcomes. So the question is, in your experience, what has been the complication that you're most afraid of? We know the typical complications of surgery, but those complications that you say, you know what, this procedure is working, but have you experienced anything that that will make you hesitant at any given point?
The the most complication that I'm always afraid, the most devastating complication that as an aortic surgeon, not only me, I think every aortic surgeon in the whole world is worried, is a stroke. Aortic surgeons are afraid of stroke. And the reason is sometimes it's unpredictable that, like, so where did that stroke come from? Even in open or endo, it doesn't matter, because with open procedure, right, you are working with all of these head vessels. With endo, or you give a lot of heparin, you're in the operative room for a long time. Or with endo, all of these wires and catheters and instruments can rub the, something on the aortic arch vessels and flip something. Even with neuroprotection, the filter that we use, still a stroke is there. Risk of a stroke with, and we publish that with any specific procedure, it's determined. It's between 3 to 8%, depends on type of the procedure. Especially if it's aortic arch procedure, risk of a stroke is there. It's 5%. So it is something that I always think about, what we can do to make that better and to make it more predictable, bring the rate down. This normothermic total arch, that is something that has been, I can say, helping bringing the risk of a stroke down to around 3%. And because you're in the operative room less, and also endovascular is important. It can help, and what is important is patient selection. If we see a patient's very ratty aorta is very diseased, full of stuff in it, then we come up with another type of plan. Instead of 3 vessel fenestrations, okay, maybe just do a carotid subclavians, just work with 1 vessel. So patient selection here is very important. which patient would be better suitable for which type of technique here.
Mhm. Mhm. And it's also important to mention that you really have brought down that dreadful mortality and also the rupture of the aorta to 60 to 70% that used to be, to a very minimum number in comparison to that bulk of patients that used to have to die simply because of complications or untimely attempts to repair. You did mention mortality from 17% to 20% in the ascending, and now obviously it has gone down, which is thanks to the technique that you're using. Not only you're using this new approach, but at the same time you are doing a normal temperature, which is also amazingly. I mean, that is mind-boggling for many surgeons to know that you're doing it at a normal temperature without necessarily having to go through the motions of the extracorporeal nonsense that we used to do, which, by the way, is still a good practice in some instances, but to do it in such a way. How challenging was that for you in order for you to say, you know what, I can actually do it minimally invasive and also remain calm with the temperature and not necessarily having to cool the temperature aside from his normal body temperature?
Right. It is, it was something I was always thinking that why we have to, because the reason the aortic procedure takes a lot of time is you have to cool the patient down. That takes about 45 minutes. And you do your procedure, and then you have to wait until you're back to normal temperature, which usually takes another 45, 1 hour. So you just sit in the operative room until temperature comes back to normal. It kills a lot of time. And in that time, patient is on pump. It's getting heparin. It's just, right? It's a lot of time just wasted in the operative room doing nothing. So we thought about, okay, what's by using this stent, we can come up with a way that we don't have to cool the patients, because we can protect the head in a in technique that I don't have time to go through the details, and we can use this stent and deploy it right away. We don't even have to cool anymore, and it bring down operative time from 8-10 hours to 3 hours, 4 hours. If the patient is 400 pounds, it will take 3-4 hours to cool and rewarm a patient, and because it takes a lot of time. But this way, you will be done in a very short matter of time.
Mhm. At a minimal risk. And the other thing to just remind our peers, it is a criteria that has changed from 5.5 to 5 centimeters. That is also a remarkable thing, which in essence will allow you to less complications for the patient and more rapid intervention. I guess the last thing that comes to my mind is how to identify those patients promptly. Obviously, there are there are symptoms that are manifesting to the cardiologist that perhaps will guide him into or guide her in order for them to say, you know what, let me do some imaging here because I think you have an aneurysm. They're telltale signs, but sometimes it is a little bit too late. I want to remind everybody that Dr. Ghoreishi performed a very complex surgery on a patient that came from Guatemala. And unfortunately, we don't have time to play that particular video, but now the patient is doing phenomenally well, and he is doing these procedures on almost on a daily basis. I don't know, Dr. Ghoreishi, if I'm lying about that, but how often are you performing this full aortic stentings?
Almost every day, like almost that's the only procedure I do, aortic procedure. I don't do and that's the super specialty we have. We are following it at Baptist. Is every group focus on one particular disease. We
Yeah.
have surgeons focusing on coronary artery bypass. We have surgeons and group focusing on the mitral valve. We have surgeons focusing on the heart failure and atrial fibrillation. My job is aorta. It's just focusing on the aorta and all aspect of this 11 segments that I mentioned,
Yes.
just either open or endo. And that's why kind of every day procedure. Like yesterday, it was a patient, 40-year-old came, third time sternotomy. And when he was a 3-year-old, he had a aortic valve replacement. When he was 19-year-old, his valve was replaced. And now, after 20 years, he's now 40, came with a severe ascending aneurysm, 6 centimeters. So we
Wow.
went back inside the chest and replaced his aorta, and he's doing fine. Again, today, another case similar to that. So kind of every day, and either open or endo. What is important is a collaborative team,
Yeah.
and working with each member of this team. It's really enjoyable, and that's what aortic center is about, to provide the best care that can be available for the specific patient.
Dr. Ghoreishi, I could have you for hours on end asking you questions, and honestly, we're flabbergasted with the incredible achievements of your department, especially of what you have achieved. I want to thank you on behalf of our entire team at International for always being so accessible and available to our international patients, and of course, to our domestic patients that you have made a difference in their lives. So thank you once again for this incredible presentation and for your time today. And to all
No,
of you for participating and listening to Dr. Ghoreishi today, I want to encourage you to take a moment and think of questions that you might have in regards to specific patients that you would think that they will benefit from a consultation with Dr. Ghoreishi. Or if you have any additional questions, please feel free to email them to us at BHIWebinars@baptisthealth.net. We'll be more than happy to share those questions with Dr. Ghoreishi for him to elaborate a response and send them back to you. We look forward to seeing you in our next cardiac and vascular lecture series that will be sending invitations to. Dr. Ghoreishi, thank you so much. Your final words.
Gerald, only thing is, I'm going to address this. This is a question I got from one of the audiences, and I think that's actually important questions. I like that. It says, how was the first endovascular surgery that we performed in order to know it's going to work? That's a very good question. Like, how can we make sure that the first inhuman type of procedure is going to work? We can't be just make stuff and go test it on. No, when we think about a device or endovascular technique, and first we test it on a back table here on my desk, make sure that actually this works and this can come together, and then we have a 3D model that we put it on in the CR, and it's exactly the 3D model. It's pumped, and the pulsatile pump, and it's attached to the pulsatile pump, and we tested to make sure this device goes to this 3D model. It's all made of silicon. It's plastic type of, but it's exactly shaped the patient's aorta, and make sure that it's working. And if it works, then we say, okay, we talk to the patients that's the other option is either no intervention and hospice. This device that we came up, it's not FDA approved device, but we've tested it. It's been working, and so that's how we came up with all of these innovative ways. But we have to do 3D ex vivo, multiple ex vivo 3D model analysis to make sure that it's working, and then put it in patients.
Thank you so much for seeing that question, Doctor. I did not see it in the bottom of the screen. I'm glad you saw it. But again, thank you so much for the explanation, and thank you all for your attention. And have a wonderful afternoon, everyone. Thank you, Dr. Ghoreishi. We'll see you in the hospital.
Thank you so much. Take care.
Goodbye.